Good morning. Welcome. We're thrilled that you are joining this Ashby Village event, Charting Your End-of-Life Journey, with Angela Schultz of Compassion and Choices. We're honored, Angela, you'll be guiding us today. Many of you are familiar with Ashby Village. Some may not be. We're a courageous and caring community of people, transforming how we age. We support each other to age with vibrancy, dignity, and purpose, wherever we call home. We have over 400 members and 300 volunteers of all ages, and a dedicated network of partners and supporters. If you haven't already, I invite you to join us as a member or a volunteer or both. Many are. We're happy to present these kinds and this quality of programming free of charge, so it's accessible to everyone. If you're able to support our ability to offer free programming, we invite you to donate to Ashby Village. We'll provide a link now in the chat, and at the end of the webinar, you can also look for a donation link in a follow-up email. Okay, Roberta, I'm turning it over to you. Roberta is a chair of our Healthier Aging program and a stalwart Ashby Village leader. Roberta will introduce Angela.
Good morning and welcome everyone to Ashby Village's Member Support Health and Wellness Lecture Series. It's wonderful to see so many of you here today with us. Member Support plans to present our health and wellness lectures at least 4 times a year, and we would really love to hear from you if you have particular topics that you'd like to hear more about. Please do put your ideas in the chat along with your questions for our speaker today, or email me directly, and Jessica will put my email in the chat as well. Our next presentation will be this summer on sleep issues affecting older adults. But today we're here to welcome Angela Schultz of Compassion and Choices, and we're so pleased to have you join us today, Angela, to speak about a topic that isn't always easy for many of us to talk about. We know that we all will reach an end point to our lives, whether it is because of a fatal illness, an accident, or just by reaching the end point of our longevity. Many of us have been encouraged to guide how we navigate the last stages of our life. And I do hope many of us have already done this by writing healthcare directives, appointing healthcare proxies, or filling out PULSE forms, which stands for Physician's Orders for Life-Sustaining Treatments. But it is only relatively recently that we've been given the legal right in the state of California, under certain circumstances, to actively end our lives and to receive medical aid in doing so, if this is what we so choose. And it is because of the hard work of organizations like Compassion and Choices that we now have this additional option about how we might manage our end-of-life journey. Compassion and Choices is the oldest, largest, and most active nonprofit organization working to educate and empower everyone to chart their end-of-life journey. Thanks to their advocacy, in 2016, California passed the California End-of-Life Option Act. Compassion and Choices continues to work to protect this act, as well as to help patients, caregivers, and healthcare professionals understand how the law works. I encourage you all to visit their website to learn more about this organization, and also to see the extremely useful resource they have made available to the public, including forms for advanced care directives that I mentioned before. Angela Schultz, our speaker today, is currently California State Manager for Compassion and Choices, where she trains and oversees volunteers in the state of California, as well as Colorado and New Mexico. She educates and orients citizens and medical practitioners of these states on the most up-to-date laws and services available relating to end-of-life options. But in addition to her rich experience and knowledge about the legal aspects of end-of-life options, Ms. Schultz also learned firsthand about the complications that can arise in having your end-of-life wishes respected when she experienced her own grandmother being put on a ventilator, despite her grandmother's expressed wish that this not be done. She also has experienced firsthand the issues that can arise when family members disagree about assisting and supporting a loved one in their chosen end-of-life path. So she speaks today not only as an experienced worker in this field, but as a part of a family experiencing the challenges of helping a loved one have his or her end-of-life wishes respected and implemented. Prior to working at Compassion and Choices, Angela worked as a congressional aide where she was involved in outreach for seniors and to the Department of Veterans Affairs. She was also involved in advancing legislation related to senior services and in following up on how well that legislation was working. She holds a master's degree in social work from Arizona State University in policy and community organizing. Angela, welcome.
Thank you so much, Roberta. Can we go ahead and share the slide? And then I'll get started. First, I just want to thank everybody so much for attending today. It was amazing to hear that we had such a great turnout for this. So as Roberta said, I am Angela and I'm the California State Manager for Compassion and Choices. And my contact information will be at the end in case anybody has any questions that they want to do some follow-up with me directly. So the first thing that we are going to go over is objectives of what we're going to cover today. So we'll cover what Compassion and Choices is, and then we'll hear from two of our storytellers, and then we'll discuss completing your advanced directives, managing end-of-life care beyond the advanced directive, end-of-life options available in California, and then other tools to finish strong. So Compassion and Choices is the nation's oldest, largest, and most active nonprofit working to improve care, expand options, and empower everyone to chart their end-of-life journey. We believe in patient-directed care, where the patient is educated and informed of their options, and then they're in charge of directing their own healthcare decisions. So this is just a quote from the book, Being Mortal, and it says, "Life is meaningful because it is a story, and in stories, endings matter." So research has shown that how people want to end their lives is at home with their loved ones, with their pain and discomfort managed, to have their spiritual needs and values respected, and without being a devastating burden to their loved ones. In reality, though, 60% of Americans die in acute care hospitals and 20% in nursing homes. And also 1 in 3 near the end of life receive non-beneficial treatments, which are often painful, uncomfortable, and futile, and have no hope of improving health while compromising quality of life. So the power of personal stories to inspire and drive change is undeniable. Compassion and Choices has a storyteller program, and I've invited 2 of our storytellers here today to share with you. I want to first introduce Julie. So Julie will share about her father's experience with medical aid in dying, which is the process that a terminally ill person who has less than 6 months to live can be eligible to receive medication to peacefully end their suffering. I'll go into more details about the criteria for this option and go over medical aid in dying further on in the presentation, but I just want to welcome Julie here and to tell her story about her and her father's experience. Thank you, Julie.
Thank you, Angela, and thank you, Ashby Village, for hosting this really important discussion and conversation. I encourage you or ask for your indulgence today if I get a little emotional when I share the story of our family's experience with medical aid and dying, because I get to talk about one of my favorite people, my very best friend, companion through life, my dad. So let me start by just telling you a little bit about my dad. His name was Barry Stroud, and he was a professor of philosophy at UC Berkeley. He came to Berkeley in 1961. So he was a professor at Cal for over 55 years. He was a very active, fit, healthy person as he aged. A very present member of the Berkeley community. If you're at Monterey Market, you undoubtedly saw him. He was a reader, a traveler. He loved to live in Venice on his sabbaticals. And as I shared, he was my very best friend. In May of 2019, virtually out of nowhere, my dad started having trouble with his gait, with his walking. His left leg, he described, wasn't really cooperating. And he began to have some unexplained falls. He went to Kaiser, Northern California, Kaiser Oakland, and his doctor told him that the problem was likely neurological. And virtually out of nowhere, he was diagnosed with glioblastoma multiforme, which is the deadliest, most aggressive, and obviously incurable form of brain cancer. They found the tumor at an extremely late stage in typical dad fashion. They were like, how could someone be walking around with something like this in their head? And doctors recommended that he forego any treatment because they said it would do more harm than good. They recommended that he enter home hospice, and they gave him a prognosis of 2 months, give or take. They told us that the disease progression was uncertain, but we were told that he might experience seizures, headaches, excruciating headaches, paralysis, losing the ability to swallow, and most important to my philosopher father, losing the ability to think. On the day of his diagnosis, my dad said, I have no interest in the longevity of my life, independent of the quality of that life. And I'm just going to repeat that because I want it to land. I have no interest in the longevity of my life, independent of the quality of that life. He enrolled in home hospice, and during his first intake conversation with the hospice nurse, he asked her about medical aid in dying, which was a law that we had celebrated the passage of years earlier, but never appreciated how closely it would impact our family. It took a little bit over a month for my dad to get the medical aid in dying medication. At that time, there was a longer waiting period, 15-day waiting period, unlike now, which is 48 hours. The month that he navigated all of the steps that it takes to get the medical aid and dying medication was a very anxious month. You imagine having 2 months to live and you spend a month of it waiting to get the medication. My dad wasn't sure if he would live long enough to get the medication or if he would be able to swallow once it arrived. He didn't know if he would still have the mental faculties to decide to take the medication. He was losing function and deteriorating every day, and we didn't know what tomorrow was going to bring. But ever the author and lecturer, my dad used the month to work on a statement he planned to make when he took the medication. His statement was, I am taking this medication to avoid a manner of living which is unacceptable for a meaningful human life. And that statement became invaluable to us because it became our shared language. My dad articulated his values, and we could talk to him about what a meaningful human life meant to him. We explored what he felt he needed to complete in his life before taking the medication. We planned who he would want in the room when he took it, what music he would want playing. And as his cancer progressed and his condition deteriorated, as he endured more unwelcome effects of his illness, we asked him daily if his condition was to him unacceptable yet. Ultimately, my dad did not ingest the medication. His condition deteriorated, but he didn't experience headaches or seizures or nausea or pain. He began to sleep more and more. He slipped into a coma for less than a day and died on August 9th, just 10 weeks after his diagnosis. Even though he didn't take the medication, I realize now that it started working the minute it entered his home. I wish I could capture and describe the day that the medication was delivered. His relief was palpable. He wept when the pharmacist left the home. And he asked every day, is the medication still where we put it? Where is it? It was like another member of the family. It was a presence in our households. And at the most agonizing time in all of our lives, the medication brought us comfort. The presence of the medication in his home and the option to take it were extraordinarily meaningful and important to my dad. It gave him peace of mind. It alleviated his fear and anxiety about the pain and suffering he would be forced to endure without it. At a time when he was losing power and control over everything, literally, the medication gave my dad power and control over his most precious resource, his life, a life he really loved. He told us that a train was coming down the tracks. We could all see it. We all knew it was coming. And the medication gave him the power to remove himself from the tracks in his own time and on his own terms. So that's our family's experience with medical aid and dying.
Thank you so much, Julie, for sharing. I heard Julie speak I think it was like my first week when I started with Compassion and Choices, and it really just, my big fear, what I want at the end of my life is not to feel anxiety. So I think that's one of the reasons your story with your father just resonates with me so much. And I just loved it so much that like your father got to spend the last couple of weeks of his life just fully enjoying, being with you, being with the rest of your family. So thank you so much for sharing.
I'll just jump in and say one more thing. He described once the medication arrived and all of that anxiety lifted about whether he would be able to live long enough to get it he described the final weeks of his life as a wonderful time, despite the dismal circumstances. And his energy and attention were freed up from his anxiety and concern so that he could do a kind of life review and experience the living memorial of love that was flooding his way. And it allowed him to be present for the end of his life in a way that he could not have been, I think, without it. So thank you.
Thank you so much for sharing. I want to introduce our next storyteller, Marcia, and she is going to share about her and her mother's experience with voluntarily stopping eating and drinking, which is an end-of-life option that a mentally competent adult can make. And I'll also review this in more detail later on in the presentation as well. But for now, please help me welcome Marcia.
Good morning, and thank you, Angela, and thank you, Ashby Village, for having this presentation. My mother, Opal Sloan, was born in 1918. She was highly pragmatic, very well organized, curious about people and places, and always interested in learning new skills and expanding her horizons. And the way she planned her death was truly in keeping with how she lived her life. In her late 80s and early 90s, my mom said many times she did not want to keep living if physical problems or mental challenges were going to compromise the quality of her life, or make her incapable of choosing how and when she wanted to die. At her senior residence in Santa Rosa, she joined a meditation group. She read about death and dying, and she took advantage of the resources available through Compassion and Choices, all which gradually led to her decision that when she felt it was her time, she would voluntarily stop eating and drinking. In her late 90s, she started having more physical challenges. She gave up driving mainly because she couldn't get in and out of the car. Carpal tunnel syndrome made using her computer and holding a fork more and more difficult. Her appetite was decreasing and her weight was dropping, and she had to rest most of the day to have energy to go to the main dining room at her residence. Day-to-day living was getting harder, and she could see that soon she wouldn't be able to leave her apartment. So it was not a surprise to me or to my husband Todd when in 2017, at the age of almost 99, she announced it was time. My father had died 27 years prior, and I was her only child, and I fully supported her wishes to voluntarily stop eating and drinking. And my husband and I were completely on board to do all we could to help her die the way she wanted. So we set the start date for her VSED, that's the acronym, voluntarily stopping eating and drinking, VSED. We set her VSED start date for 3 months down the road, which gave my mom time to finalize her affairs and get organized for this VSED journey. For the memorial announcement I would send out after she died, she wrote, "I have lived a long and happy life and feel I have come to the end of it. I'm thinking of my passing as a new adventure, wondering what will happen." She'd recently seen her doctor, who had written her a diagnosis of failure to thrive. And when she asked him about VSED and how long the process usually takes, he estimated 2 weeks to a month, perhaps less for her. As it turned out, my mother's VSED journey took 7 days. Because she did not have a 6-month terminal diagnosis, the local hospice, which was dependent on reimbursement from Medicare, could not provide care. But there was no way my mother would be deterred. She had the round-the-clock care she needed from me, my husband, and several relief caregivers, the support of the nurse at her senior facility, the commitment of her doctor who prescribed sedation and anti-anxiety medications and who signed the death certificate after she died. But most importantly, my mother had the strength of her own resolve. On her first day of stopping eating and drinking, she said that for several days prior, she had been eating less and not missing food. She said, "I'm telling myself I don't need food and I don't need this world." And that day, the two of us looked through family photos and she enjoyed it immensely. On the morning of day 2, she experienced several hours of dry heaving, after which she felt better and slept and rested. On day 3, she seemed back to her old self, wanting me to make sure her TV cable provider had discontinued her TV service. I had brought some music CDs, and she most enjoyed recordings of my husband Todd playing solo piano, slow, spacious music without a regular pulse. And I'm a cellist, and 2 days later, I improvised on cello for her as she drifted off to sleep. In the course of the week, Mom came up with hand signs in the event she could no longer speak, tracing her mouth with her finger for when she needed her mouth swabbed, making a fist and moving her arm for when she needed morphine, the AOK sign for yes and waving her finger for no. And on the evening of the 6th day, Mom traced her lips to indicate she wanted her mouth swabbed. And that was her final request. And the next morning, in her sleep, she took her last breath. I kept a journal of my mother's VSED week as a record of the experience both for myself and to share with others. Before she undertook the VSED process, I couldn't imagine that anyone could dictate their death so much on their own terms. But she did it. And from how she described what was happening to her that week, to her, dying felt no better or worse than how we feel in the midst of life. I stand in awe of my mother's courage. And I deeply appreciate having been able to witness the preparation, clarity, and fearless resolve that marked her choice to VSED. I see that knowing she could VSED when she was ready was tremendously empowering and reassuring for her. And I came away from my mother's VSED week less in denial about my mortality, less afraid of the death of my physical body, and more interested in thinking about how to prepare so I'll feel ready when it's time and can surrender as she did. We won't all have the same experience as my mother, but I hope her story encourages us to think about our death with the same curiosity and openness with which we think about our life. Thank you.
Thank you so much, Marcia. It's hard for me to follow up, I feel like, with them. So I'll try, but they're so powerful. I just really appreciate both you and Julie coming and sharing your story. And I hope that by hearing these stories, this will encourage you, if you haven't already, to have these conversations with your loved ones and your healthcare team so that you can have the end-of-life experience that you're looking for. So it's important to plan for your future. However, before you can make plans for your future, you do need to ask yourself some important questions. What are your values and goals of medical treatment? How do you define life? What matters most to you? What brings you joy? Compassion and Choices has an end-of-life decisions booklet, and it's very helpful in walking you through this part of the decision-making process. It can be downloaded from the Compassion and Choices website. You can order it on our website, and then we'll send you, it's like a 50-page booklet. And then I've also mailed Roberta a few copies of them, and then some postcards that you can just fill out, put a stamp on, and submit it, and then we'll mail you the booklet as well. So advanced planning is key. As both Julie and Marcia talked about, their parents knew kind of what end-of-life experience they wanted and shared it. So making thoughtful choices now, putting them in a written advance directive, and discussing those choices with others. Advanced planning helps ensure that we get the care we want and avoid the care we don't want, even if we're unable to speak for ourselves. I'm not going to go over the advance directive, the living will, so much because I'm hoping that most people have one, but they estimate about 2/3 of the American public doesn't have one, but that's actually estimating for everyone 18 and older supposed to have one. When it comes to adults, it can range anywhere, unfortunately, from about 25% to 50% of adults over 55 have their advance directive. So most commonly, what's in an advance directive is going to be your living will and your healthcare proxy or medical power of attorney. So in this document, you specify in advance what kind of medical care you would want if you were to become incapacitated. And then you can identify another person as well as alternative people should the first person be unavailable as your healthcare representative. And often what is included in the advance directive will be options for artificial ventilation. This is sometimes called mechanical ventilation. So this is often used when patients cannot breathe satisfactorily on their own. So a tube will be inserted through the mouth into the windpipe, and then a machine pushes a precise combination of oxygen and air into their lungs. The tube can also be inserted through a hole in the throat. And then some people are given artificial ventilation and slowly weaned off it, but many others are unlikely to recover the ability to breathe on their own. The longer a person utilizes artificial ventilation, the less likely recovery becomes. And then medications to stimulate heart function. And so if you think about this in terms of if you're taking medication for your heart, and if your heart were to stop, if you want it to be restarted. So one thing that we often talk to people about too is if they're terminally ill, maybe if something were to happen, you wouldn't want to be given your heart medication to restart it. And you would just want if that only prolongs the dying process for you. And then artificial nutrition and hydration. So nutrition and hydration is provided for people who cannot swallow, if they can't swallow sufficient amounts and cannot absorb nutrition through the stomach. So a lot of times these tubes can be inserted either through the nose or also through the stomach. And artificial nutrition can be a really good option if somebody has surgery and they just need it temporarily for recovery. But usually at the end of life, if someone has a serious and life-limiting illness and they're no longer able to eat and drink, this means that the body's beginning to shut down and stop functioning. And using artificial nutrition and hydration will not bring the person back to a healthy state. Another thing to consider with artificial nutrition and hydration is that it can also increase suffering and cause further discomfort. It can often lead to bloating, swelling, cramps, diarrhea, and shortness of breath. So I do want to go over choosing a healthcare power of attorney. So in selecting a representative, ask yourself, is this person assertive? You want to talk to someone, or you want to pick someone who's comfortable speaking with healthcare providers and advocating for you. Are they comfortable talking about death? Given that they will need to engage on this subject, do they live nearby? If you're having a crisis, having someone local can be important. And then will they respect my decisions? They need to understand where you're coming from and be willing to honor your request. I often will share with my friends, before I started working here, I had selected my husband as my healthcare proxy. And then when I started working here and just hearing stories that our volunteers tell us, I switched it over to one of my friends who is also a social worker. But she's like 5'2", but we call her like a bulldog kind of. And when I told my husband, I said, I'm going to switch this over and make Michelle this. My husband is so nice. And I could just see like his initial response was like, why would I do that? And then I asked him, would he be willing if I no longer wanted to live, right? If I was going to have to be hooked up to machines the rest of my life. And then I saw the look on his face of realizing that he wouldn't be able to do that. So sometimes when we're talking about who should your healthcare proxy be, I think a lot of times people think about, family members, but it can, a lot of times they're going through their own grieving process. So picking somebody who's kind of outside of that might be helpful because a lot of times people don't make the best decisions when they're grieving, unless you feel like, again, really comfortable with moving forward with that person. So here are some options to consider. So in some cases, it may be better to ask a nearby friend who you trust. You could consider asking your neighbor or a member of your faith community. When discussing your request, let them know that there's no financial liability attached to this role. Some local senior services or elder care agencies also have programs where they either have volunteer or staff members that are willing to be the healthcare power of attorney. If you're on hospice, you can discuss this with your hospice provider. And then also attorneys who specialize in elder law may be willing to take on this role as well. And then we also encourage people to review their advanced care documents during when any of the 5 Ds occur. So this would be when someone close to you dies, when there's a new decade, when you go through a major family change, such as divorce, if you receive a new diagnosis, or if you experience a significant decline. And then I also want to go over just charting your wishes beyond your advance directive, just the living will. So you may be familiar with the orange paper. So be aware that your advance directive may not be effective in the event of a medical emergency. So ambulances and hospital emergency departments are required to provide CPR unless they are given a separate directive that states otherwise. These directives are called do not resuscitate orders. A newer term kind of coming out in case you hear it is allow natural death. But these are designed for people whose poor health gives them little chance of benefiting from CPR. These directives instruct ambulance and hospital emergency personnel not to attempt CPR if your heart or breathing should stop. Discuss with your doctor if such an order is appropriate for you. A DNR is used in medical settings, while a pre-hospital DNR is used outside of the hospital setting. An attending physician will not issue an out-of-hospital DNR order if the person requesting the order is not eligible for it. Most physicians will only sign the document for a person who is terminally ill or extremely elderly and frail and mentally capable of making such a request. You can print this form in color on letter-sized paper and then display it in plain sight in your home. I have heard from a lot of volunteers that they have their houses set up like this, or their parents had this, where they have several copies of their DNR and out-of-hospital DNRs, just up on the fridge, on all the doors in their house. People can go a little wild with it. But it's important because it can, in an emergency, there's often limited time. So the more you can be transparent about it, the better. And then you may also print the form in color and put it on a wallet-sized paper. I've also had volunteers tell me that they will share this information with their neighbors. That way, if, the ambulance comes to their house or fire department, the neighbors sometimes come out and share that they have the DNR as well. And this form must be signed by you and a licensed healthcare provider as a witness. And then Roberta mentioned the POLST as well. So this stands for Physician's Order of Life-Sustaining Treatment. So this covers other areas such as CPR, ventilation, and other interventions like feeding tubes. So your doctor will make the determination and has to sign it. It's, again, only for seriously ill and frail patients. The original POLST form will remain with the patient, and it's typically on bright pink paper. And then we also have, it's on our website, it's also in the booklet that I mentioned earlier, the end of life, the planning for your end of life. But we recommend carefully checking out healthcare facilities in advance to see whether or not they will honor your wishes. You want to make sure that they'll honor your wishes if you want to stop medications and that your end of life treatment options will be respected. It's important to confirm that you will get pain medication needed to feel comfortable. Often known as comfort care as well. On the Compassion and Choices website, you'll also find the following resources. So the Sectarian Healthcare Directive, this is an addendum to your advance directive to clarify your wishes supersede those of an institution's religious policies, and that you wish to be transferred if any facility refuses to follow the preferences you've outlined in your advance directive. So this is something that I feel like a lot of people are interested in. Some Catholic hospitals are, especially if you're in a rural area, they merge or they will buy the local hospitals. And sometimes it's a little tricky to tell if that hospital is part of a religious institution. But Catholic hospitals in particular have what's called their ethical religious directives, which those can sometimes trump what your advance directive says. So if you say that you don't want to be on a ventilator, but you go to a Catholic hospital, they can decide, to put you on a ventilator. So if you sign the Sectarian Healthcare Directive and add that to your advance directive, and then have that conversation with your family and your doctors, that will help you in those situations. And then an assisted living facility writer is a contract writer for people who live in assisted living facilities and would like to stay there until they die. So this ensures that the individual's home is suited to their choices. I've actually been having some conversations a lot with volunteers, and I just had an assisted living facility reach out to me this morning, and they want to have a conversation because they have been having a lot of questions around medical aid in dying. And I just found out yesterday from one of our volunteers that someone who was living in an assisted living facility didn't know if they would allow them to take the medication there. And so they just didn't tell them and ended up taking the medication. And so the volunteer has reached out, and she's actually a doctor. And now we're working to set up a model policy with that assisted living facility, because it kind of came as a surprise to the director of the assisted living facility. And then a hospital visitation authorization form enables people not traditionally recognized as family members to gain priority visitation rights. So once completed and signed, it should be kept with the advance directive. And so this is the most important part of the presentation. So you cannot do this alone. Not including your family and loved ones in your planning will definitely leave them with regrets and questions after you die. And not including them will make it less likely that your plan, whatever it is successful. It's important to sit down with your family and have this conversation. In the Compassion and Choices End of Life Toolkit, there's suggestions on how you can start the conversation, such as if you are ever in a position where you need to make healthcare decisions for me, it would be helpful for you to know what I really want. They also talk about doing this over like Thanksgiving dinner. That way, usually all family kind of gets together so that you can have that conversation with everyone. And I know Roberta had shared kind of what happened with my grandmother, and it was more of an unfortunate event where my mom, who lived closest to my grandmother, was at work. And my relatives from a couple states away happened to be in town, and my grandmother didn't have the kind of conversations with them. So they were trying to do whatever they could to save my grandmother's life. So again, it's important to have these conversations with everybody, even if they're not your healthcare proxy. I think the more people are aware and on board with what your wishes are, the better it's going to work out for you. And so now we're going to go through end-of-life options. So researchers at Stanford investigated whether doctors and non-physicians attach different meanings to the word treatable. Researchers found that non-physicians, so most likely you and I, patients, hear treatable as a positive message about the patient's future. They hear that the disease can be cured or at least contained, so it does not seriously diminish the quality of life. If the doctor also shares dire news about the overall prognosis, non-physicians discount it and come away with only the good news of treatment. But the study revealed that doctors mean something quite different by the term treatable. Doctors say treatable when they don't want to say incurable. When doctors use the word treatable, they simply mean there is treatment that can be applied. Doctors do not mean to imply that the treatment is likely to succeed, or that if it does succeed, the disease will go away or increase quality of life. They don't even mean treatment will prolong life. The chance that this treatment to prolong life might be very small, and the doctor will still say treatable. Researchers concluded that physicians use the word treatable may lead patients and surrogates to derive unwarranted good news and false encouragement to pursue treatment, even when physicians have explicitly stated information to the contrary. This very unfortunate confusion over the word treatable is avoidable. Numerous studies suggest that more patients and their loved ones prefer candor from their doctor over vague terms that lead to false hope. People would like to make plans and treatment decisions knowing the realistic benefits, burdens, and full risk of any course of treatment. So death finds us all eventually, and we can't prevent that, but we can direct how we'd like our final days to unfold. You can always pursue all treatment options. Palliative care focuses on pain management and comfort care. Pain and symptom management involves the use of medications and other therapies, such as massage, acupuncture, aromatherapy to bring comfort. Symptoms may be disease-related, such as pain, shortness of breath, or sleeplessness, or they may be side effects from treatment, such as nausea from chemotherapy. You do not need to have a terminally prognosis to receive palliative care. And then palliative care is available in medical and assisted living settings in the home. So I just want to kind of restate that again. So you don't need to have a terminal prognosis to receive palliative care. So if you've been diagnosed with cancer, you could ask your doctor if you're eligible for palliative care to get these extra benefits to provide comfort, even if your cancer is not terminal. So hospice is a service that provides compassionate medical care at the end of life. The patient's primary care physician makes the referral to the hospice once they determine that the patient will most likely die of their disease within 6 months or less, with the goal of maintaining or improving quality of life. It involves an interdisciplinary team of caregivers and often includes doctors, nurses, home health aides, social workers, chaplains, and trained volunteers. For those who have appropriate medical referral, the cost of hospice care is usually covered by Medicare, Medicaid, or third-party insurance. Hospice can take place wherever the person resides, most often in the home. Hospice also provides counseling. It can provide bereavement counseling to your family, family support, and end-of-life planning. Voluntary stop eating and drinking, which is the acronym and what most people commonly refer to as VSED. This is a conscious decision to refuse food and fluids of any kind, including artificial nutrition and hydration. So VSED can be sought at the home or in a care facility, but it should be medically managed to minimize discomfort. You cannot do this alone. You will need 24-hour care during this process and ongoing hospice care or oversight by your physician. The most frequent reported symptoms include thirst and dry mouth and occasional hunger. So the U.S. Supreme Court affirmed this right that a decisional capable individual can refuse food and water. Not everyone is understanding and supportive of this choice. If you reside in a care facility, discuss your wishes with the nursing director or the social worker. You will need their agreement to support you. You will need to make arrangements for 24-hour care once the VSED process has begun. Acknowledge to your caregivers that if you request nutrition and hydration, you understand that they are ethically bound to provide it. However, you can discuss ways on how they might respond to remind you of your original intention. And so we have webinars too that will give examples of how you can do this. So one that I really like is if I call, my caregiver in and I say I'm already in the voluntary stop eating and drinking process, and then I say to my caregiver like, "Oh, I'd really love some eggs." I can tell them like, it's okay to say, "I'm happy to get you some eggs, but I do want to remind you that you wanted to go through the voluntary stop eating and drinking process. Is this still what you want to do?" And then I can restate, "Oh yes, that's what I want to do. Please don't feed me." Or it does happen, people make the decision to do it and then they decide they do want food or water. So palliative sedation is an end-of-life option that is practiced in rare circumstances. This is sometimes referred to as terminal sedation. And this option involves being medicated to reduce consciousness. This is for people whose symptoms and pain management cannot be managed while conscious. Palliative sedation must be medically managed by a healthcare provider. Palliative sedation is ordered by the patient's physician after carefully evaluating the patient's symptoms, disease process, and prognosis in discussion with the patient and the family and caregivers. The sedating medications can be given to the patient in several ways, but it's most often by IV form. And then medical aid in dying. This is authorized in 11 jurisdictions, including California. And to be eligible for medical aid in dying, a person must be over the age of 18, have a terminal illness with a 6-month prognosis, be mentally competent, and be able to self-ingest. And so now we're going to go over medical aid in dying in more detail. So the end-of-life care options movement is growing strong. So there's 10 states, California, Colorado, Hawaii, Montana, New Mexico, Oregon, Vermont, Washington, New Jersey, and Maine, and then plus Washington, D.C., have authorized medical aid in dying. This has been done in Colorado. It was a ballot initiative, and then in Montana, this happened through the state Supreme Court ruling. And all of the other states was done through state legislation. So this means that over 1 in 5 Americans currently have access to this peaceful end-of-life option. So in 1997, the United States Supreme Court, after hearing 2 different cases related to medical aid in dying, declined to recognize the federal constitutional right to medical aid in dying. However, the court did say that individual states can address this issue. So this is why we have to kind of go state by state for medical aid in dying. And if you move from one state where it's authorized to another state where it's authorized, the law may vary different between each state. They all have the same basic requirements that I just went over, but each state may have like specific like unique options to them, different waiting periods, different amount of times that you have to have an oral request. But we'll go over California specifically. So in order to get a prescription, the eligibility requirements, again, is that the individual must be a resident of California. So in Oregon, just last year, we have a legal department, and they had filed a lawsuit primarily because there was a patient in Washington, and they saw their doctor right across the border over in Portland. And that patient in Washington wasn't able to get medical aid in dying from their doctor in Portland, even though they're very close to each other. And so that we worked with that patient and filed the lawsuit, and were able to win that and get rid of the residency requirement in Oregon. So essentially somebody who, if you live in Texas and you decide that you want to do medical aid in dying, you could move to Oregon and use this option. But we also know that most people do want to die in their own home. So we keep working on passing legislation. And it also can be very difficult to travel if you're terminally ill. But it is an option. I just wanted to put that out there. A person must be an adult who is 18 years or older. The person must be terminally ill with a prognosis of 6 months or less to live. The person must be capable of making medical decisions, and the person must have the ability to self-ingest the medication. So if they're unable to swallow still, they can use a feeding tube or an anal catheter, as long as they are still able to push the plunger themselves. So if you meet all of these requirements, you can ask your doctor for a prescription and pick it up. So just kidding. That's not how it works at all. I say this because a lot of people think this is how it works. And I know when Julie shared about her father and saying that it took them about 30 days to get the medication, but now it's taken from 15-day waiting period to 48-hour waiting period. It can still take 30 days to get the medication and still go through the process. And we'll kind of cover that in a little bit as well. But this is why it's so important for people to know the process so that they don't wait until the last minute to start it. So other requirements of the law include that the patient must make 2 verbal requests, a minimum of 48 hours apart, and 1 written request. The written request form we have on our Compassion and Choices website. And if you just Google, the easiest way to get it is Google Compassion and Choices California. And off to the side, it'll say for patients and like providers. And you just click on for patients and you'll find a bunch of resources for medical aid in dying will pop up. It's important to also ask the physician to make sure that these requests are documented in your medical record. 2 physicians must confirm the patient's eligibility, and the attending physician must inform the person about all of their end-of-life options care. And then 2 witnesses must sign the written request and attest the voluntary nature of the individual's request, and only one of them can be a relative. And then other provisions of the law. So wills, contracts, insurance, and annuity policies are not affected if a person uses medical aid in dying. Medical aid in dying is not considered suicide or assisted suicide. We have worked really hard with legislation to let them know that people who use medical aid in dying want to live and that they have a terminal illness that is killing them. So on the death certificate, if somebody uses medical aid in dying, that will not be listed as the cause of death. The cause of death is the terminal illness. And then talk with your doctor. So this is the most important thing you can do, is have this conversation with your doctor. So you must find a doctor who's willing to support you through the whole process and write the prescription if you qualify. Sometimes this can be very difficult depending on where you receive care. When you talk to your doctor, it's important that you are clear and that your request, and you ask your doctor to write down your request. We have heard from patients who thought their doctor was on board, but when the time came, their doctor refused to support them. Remember, you don't have to be sick to ask your doctor if they would support you in this option should you become terminally ill. It's better to find out as soon as possible if having this option is important to you. So what happens if your doctor does say no? So there are several reasons why a doctor sometimes do not support their patients in the option of medical aid in dying. So you should try to find out why. So is your doctor allowed to prescribe? 97% of religious hospitals in California, like Dignity Health or Adventist, do not allow their doctors to practice medical aid in dying, even if the doctors want to. If you are at a secular system that does not allow doctors to prescribe and want to try to get them to change their policy, let us know and we'll see what we can do to help you. We encourage all healthcare systems and hospices to have a neutral policy that allows doctors to support patients in the option of medical aid in dying. It could be that you're their first patient requesting medical aid in dying. Quite possible that your doctor may not know much about it. In fact, most doctors are not trained in end of life at all, let alone on medical aid in dying. If you think that your doctor might support you, please share with them our free confidential consultation doc-to-doc phone number. Your doctor can use it to talk to another doctor who has prescribed medical aid in dying and can walk them through the process. If your doctor absolutely refuses, ask them to refer you to a doctor who will support you. Hopefully they will not abandon their patients. And if this is what you want, they may even help you find someone to support you if they cannot support you themselves. Finally, you can always reach out to our end-of-life consultation for support, and we will try to help you. So you might notice I highlighted both our doc-to-doc line and our end-of-life consultation line. It's the same phone number, and what happens is when you call, if you're calling for the end-of-life consultation program, you would call and you push to be connected to end-of-life consultant. You leave a message, and then they will call you back within 48 business hours. So next steps. Once you find a doctor, there's still a few more steps. The good news is that finding a doctor is usually the hardest step. If your doctor is supportive, they will help you get through the rest of the process. Your main doctor should refer you to a doctor to act as the second doctor to confirm your eligibility, which is step 2. Then number 3, you must make a second oral request to your main doctor, separated by a minimum of 48 hours. Finally, number 4, you will need to complete the written request, and this can be submitted to your doctor during that 48 hours. These are the main steps, and once you have made the second oral request, it generally takes about 7 to 10 days to fill a prescription, but this can also take far less time. It just depends on the healthcare system or hospice that you are receiving care from. If your doctor doesn't know where to fill a prescription, again, you can refer them to the doc-to-doc consultation, and we can provide the doctor with pharmacists who can fill the prescription for you. And then I want to talk about improvements to the End of Life Option Act. So as Roberta mentioned, California passed this legislation in 2015, and this became an option for terminally ill individuals in California in 2016. So we worked really hard with some amazing volunteers on passing Senate Bill 380 in 2021, in October of 2021, actually. So the law went into effect on January 1st, 2022, and it maintains the California End of Life Option Act's core eligibility requirements, but with some improvements. So one of the things that this bill did was reduce the mandatory minimum waiting period from 15 days to 48 hours from making the first oral request to the second oral request. So we had found that this waiting period actually was a suffering period, and as a result, many patients were unable to get through the lengthy process. There was just a movie that came out that a lot of our volunteers had seen. It's called Last Flight Home, and it's a documentary that a woman did when her father used medical aid in dying. So in California. So if you were to watch that, they talk a lot about the 15-day waiting period. So do want to specify that because of this new law, it is now only 48 hours. However, just because the minimum waiting period is 48 hours, this does not mean that the whole process is 48 hours. It can take time to get your appointments with your doctors, to get your witnesses, and to obtain the medication. I think that Kaiser has said it takes about 3 weeks to go through the process with them. And then it also clarifies that an oral request for medical aid in dying should be dated and documented in the individual's medical record and remain valid even if the care is transferred to another attending physician. So again, these changes were made because some patients were having to restart the entire process after care was transferred, resulting in many dying before they were able to complete the process. So that goes back to making sure that when you make this request, asking your doctor to document that in your medical record, because that will be your first oral request. And then the End of Life Option Act provides attending physicians should remind qualified individuals to not self-administer medical aid in dying in a public setting. And so this created confusion about whether healthcare entities are considered public under the Act. So SB 380 clarified that healthcare entities are not considered public settings and qualified individuals may self-administer within healthcare entities if that is what they want to do. But again, most individuals choose to die at home. And then SB 380 also incorporates 3 provisions that facilitate transparency in care. It requires that healthcare entities post their policies about End of Life Option Act on their website. It clarifies that healthcare entities cannot bar healthcare providers employed by them from providing truthful, accurate information and or referring patients that have questions about medical aid in dying. In the bill clarifies that providers have the option to object to medical aid in dying should, at a minimum, document the patient's date of request and the provider's notice of their objection in the medical record, and then transfer the individual's relevant medical record upon request. So what I sometimes will do is when I'm looking to see if a hospice is supportive of medical aid in dying, I just Google the name of the hospice and medical aid in dying policy. And sometimes what will happen is I'll be directed right to the website where it states what their policy is. And some of them it's very clear to me that they will help you through the process. And some of them that sound more confusing. I get the idea that, a lot of times what happens with hospices is that they require that the staff leave while the patient takes the medication, and then the staff can come back in and then continue working with the family afterwards. But what we have found out is that a lot of healthcare entities, probably my guess is that maybe they don't know that this was passed. They get so many emails and have so much work to do. So a lot of healthcare centers and hospices don't have their medical aid in dying policy listed on their website. So we currently have volunteers reaching out to hospices, trying to find out what their policies are, letting them know that the California End of Life Option Act, that Senate Bill 380 went into effect, and we have model policies we can share with them. We have policies from other hospices and healthcare systems that we can share with them. And we're totally, the California End of Life Option does not mandate that any healthcare facility needs to participate in it. We just think that patients should know if it's something that they're interested in before going in. So it's fine if the hospice doesn't want to participate, but what the law would state is that they would state on there that this is a hospice that does not participate in the medical aid in dying process. And so the last transparency part of that, number 3 that I had talked about, requires the doctor to write down in your medical record that you were requesting medical aid in dying, and then write down that they do not want to participate in this process, and then transfer your records. And so there is a group called the Christian Medical and Dental Association, and they filed a lawsuit actually against the state of California to seek provisions made to the medical aid in dying bill of Senate Bill 380. So they did this in February of 2022. So the plaintiffs erroneously argue that the amended California End of Life Option Act forces physicians to participate in medical aid in dying, and therefore violate their First Amendment rights of free exercise and free speech, and their 14th Amendment rights of due process and equal protection. So we consider that every aspect of medical aid in dying is voluntary, including physician participation. So non-participating physicians, all they have to do, again, is what we consider to be their general basic professional obligations, and meet the minimum standards of medical care by informing their patients that they do not participate in this option, by charting the patient's request, as well as the physician's objection, and then in the patient's medical record, and then transferring the patient's medical records. So they filed the lawsuit, we filed a motion to intervene. And as of right now, where this stands is that the court came out with a decision in September, and they partially granted the plaintiff's motion. And so they suspended the requirement that a non-participating physician document a patient's request for medical aid in dying and the physician's objection in the patient's medical record. So as it currently stands, which is why I keep going over saying how important it is that if you're terminally ill and this is the option that you want, really try to make sure that your doctor documents it, because even though that's part of what we passed in SB 380, because of this lawsuit right now, a doctor doesn't need to write that down in your medical records. So again, we consider that, your medical records belong to you. And so we consider anything that we, meaning Compassion and Choices in our legal department, that if you're making the request to go through the medical aid in dying process, that should be documented in your medical records. Patients, not physicians, own those medical records. So we filed a motion for reconsideration in September on this topic, and we're still waiting for a decision on that. So again, this is why it's so important to start the process as soon as possible once you are terminally ill with 6 months or less to live, if you think you want the option for medical aid in dying. As Julie stated, I just want to remind you that you can go through the whole process and never use the medication if you change your mind. So talk to your doctor right away. Ask them if you were to become eligible for medical aid in dying, would they write the prescription for you? Would they support you in the process? And then don't be afraid to ask. You're your best advocate. Medicare now also covers, I think it's like a 30-minute consultation about end-of-life options with your doctor. So you can go in and have those conversations with your doctor. Your doctor may also need time to process it. We have a really great story from Hawaii where the doctor was Catholic, and even though the hospital they could prescribe, the doctor did not want to participate in the process, but he had been the patient's physician for like 20 years. And she kept asking him, like, please, will you go through this process? And he did his own like soul searching and decided that since this is an authorized option in Hawaii, he would go ahead and write the prescription for her. And so he wrote it. He wasn't totally on board yet. And then she had the day that she was going to take it, she had a little celebration of life and she invited him. And he didn't want to go to it. And he's like, it would mean so much to me if he came. And he ended up going to it and said it was the most peaceful death he had ever seen. And he's called us and he's like, I'm totally on board now. And will, is always willing to like help out when we're trying to make improvements in Hawaii as well. So sometimes, your doctor just needs more information on it. A lot of times it seems like the doctors just need more information. So again, we have that doc to doc line. We have little palm cards that we can send you if you want to give to your doctor or to your doctor's office. The more ways we can get this information out in the community, the better. And so now we're going to talk about dementia and end-of-life care. So dementia is just an umbrella term for progressive loss of memory, language, cognitive abilities, and functional capacity serious enough to interfere with daily life. So the most common type of dementia is Alzheimer's disease, and this accounts for about 60 to 80% of all dementia cases. So mental decline looks different for everyone. Sometimes patients' personalities change towards the end stages of dementia in addition to memory loss. And then most cases of dementia can last 8 to 10 years. During advanced stages of dementia, most people endure irreversible loss of mental and bodily function in which they cannot recognize their loved ones, they cannot recognize surroundings, they cannot speak or make oneself understood. They experience personality changes, and then they can also not respond to environment or control their movement. However, as I said earlier, dementia is a progressive disorder. Many people can live meaningful and enjoyable years after the onset of dementia. And then I just pulled some information about California's specific in Alzheimer's disease. So in the US, more than 6 million Americans have Alzheimer's disease, but there are approximately almost 700,000 Californians over the age of 65 living with Alzheimer's. And this affects more than 1 million caregivers. And then in 2025, it's expected that by 2025, there'll be a 21% increase in cases in California. California ranks number 10 in the US with the highest death rates from Alzheimer's. And then nearly 2/3 of people living with Alzheimer's disease are women. And then Black Americans are twice as likely to develop Alzheimer's disease than white Americans. And Hispanic and Latino Americans are 1.5 times more likely to develop Alzheimer's disease than white Americans as well. And then in April of 2022, a University of Michigan study found that 1 in 2 adults now die with a dementia diagnosis. So they did this again by looking at the death certificates and finding out how many listed dementia. It might not be like the cause of death, but was listed as secondary. So do I have any end-of-life options in the case of dementia? So absolutely. Every adult with a mental capacity has the right to document their desire to forego medical treatments. In the early stages of dementia, patients can choose to use voluntary stop eating and drinking, or VSED. So as a reminder, voluntary stop eating and drinking is a conscious decision to refuse foods and fluids of any kind, including artificial nutrition and hydration. So VSED, sometimes people get VSED confused with at the end of life. Sometimes people just stop wanting to, like they just stop eating and drinking as they get so frail. VSED is more, it's a conscious decision that you're making. So if you have advanced dementia, this would not be an option for you because you do have to be mentally capable of making your healthcare decisions when you start the voluntary stop eating and drinking process. But I have a coworker whose mother, when she got diagnosed with Alzheimer's, while she still had decision-making capabilities, went through the VSED process for that. So again, we encourage you to make sure that you have supportive doctors, a supportive healthcare team, and have 24-hour care once the VSED process begins. When choosing VSED, it is difficult to predict exactly when the end will come. This will depend on the person's physical condition, their age, medications they may be on, any illnesses that they have, the height to weight ratio, fluid retention, ability to remain completely free of all fluids, and then also perhaps just a willingness to let go. So for a terminally ill person, this process may take several days to several weeks after intake of food and water stops. Some people experience unconsciousness in as little as 2 to 3 days. Since the length of time is unpredictable, planning ways to bring meaning, pleasure, and comfort during this time may help reduce anxiety about the length of the process. Dying patients may want to choose favorite movies, music, poetry, and passages to read or have read to them, share memories or favorite stories with photo albums or scrapbooks for prompting, keep a journal in the written form, video, and audio notes for loved ones, create some type of legacy project to leave behind for loved ones. And then they can also ask their caregiver to do things like applying body lotion to keep their hands and skin hydrated, or use gentle touch and massage to help ease suffering. And then Compassionate Choices also offers a dementia addendum to your advance directive. So you can find this online, or it's also written in that booklet. Near the end of it is like the last 3 are addendums to your advance directive, but the dementia addendum is right before that. It's probably about 15 pages long. And I'm just going to go over briefly some screenshots that I took from the website to kind of walk you through this process. So the Dementia Values and Priority tool helps people stay in control of their life should dementia take hold. You are able to provide a set of clear-cut instructions to your loved ones, outlining your intentions through a personalized care plan called a Dementia Healthcare Directive. And then you can add this to your advance directive as well. So this also gives loved ones a way to implement critical, informed decisions on your behalf, guilt-free. And so you may complete this if you have been diagnosed with dementia, but only if you are still making your healthcare decisions and have the mental capacity to do it. So if I were to do this for myself, I have done this for myself, but I would select the second option over here, which says I haven't been diagnosed with dementia. So I select that one, or again, on the left, you would say I have been diagnosed with dementia, and it just takes you through this tool. So you will be asked a series of questions, and you select your care preferences for each of them. So it goes through about 15 care markers, and then you will select which care option you want. And so the care preferences are, I want to live as long as possible. So this would mean I want all life-saving treatments and procedures. This can include surgeries, ICU, ventilators, CPR, and feeding tubes. The next option is I want no life-saving treatments. I want short-term urgent medical treatments, including acute care and admission to emergency rooms. This would mean I do not want CPR, ventilators, feeding tubes. And then the next option is keep me comfortable and stop or avoid any treatment that is preventing me from dying from other diseases. So this would be like antibiotics or heart medication. So this is that you want to receive comfort care, but you do not want any life-saving treatments or acute care. So the focuses will be on aggressive pain and symptom relief, including breathlessness, anxiety, and agitation. And then the last option, again, which is different than voluntary stop eating and drinking, is keep me comfortable while stopping all treatments and withholding food and water so I can die peacefully. So this would be more along the lines of if you, like you don't want to be spoon fed. So if somebody were to take the, food up and, to your mouth with your fork and you turn your head, you don't want them to continue trying to force feed you at that point. And I do want to highlight, I think it's really important because I often get questions about this, is how do I relay this information about what the care preferences are? So that question mark is on every single page on our website. And if you just click the question mark, it pops up this box. And what I always recommend is printing this page and attaching it with it so that there isn't confusion about what levels of care you want. And that first one, I'll just go back and say, because I didn't say it, but the first question is, I have forgotten everything about my past, but I still recognize those closest to me. For me, again, this is all individualized. I said, I want to live as long as possible. So if I have forgotten everything about my past, but I still recognize my family and my friends, I would say I'll go ahead and have surgeries, or I'm okay with going to the ICU. And then another example would be, this one says, I no longer recognize my loved ones, and more often than not, I seem unhappy, sad, or anxious. So this is not how I want to live. So I selected keep me comfortable and stop and avoid any treatments that are preventing me from dying from other illnesses. So if I get pneumonia, don't treat me for my pneumonia. Just let me go through my pneumonia. And then on the next, at the end of it, it will, as you go through the 15 markers, you can pick your healthcare proxy. And then there's also a section to exclude people from having any sort of decisions in your healthcare decision. So this could be if, you and your children might have very different beliefs about end of life. And so if you want to make sure that, your child that you love a lot, but has a very different, belief about end of life than you do, is not able to make decisions, you can put them in here. And then what you would do is fill out, if you're doing the tool online, you fill out the patient information, and it will populate a written dementia provision that you can attach to your advance directive. So if you're able to see this, I'm not sure if you can read how small it is, but it goes over some of the other markers on there. So some of the other ones are, I can no longer feed myself. I can no longer bathe myself. I can no longer toilet myself. I can no longer dress myself. There's an option to put your own marker in. Or if you're doing the paper one, you can just write your own marker in and say what it is. So for me, I love being outside. So if I am ever in, a skilled living facility or nursing home, and, the windows don't open and I'm not able to get outside a couple times a week, probably every day, then I would want to, go through the process where I'm not eating and drinking anymore. So again, you cannot do this alone. So if this slide looks familiar, it's because you've already seen it. This is your reminder that the most important thing you can do is to ensure that you have the end of life experience you want or don't want, is to talk to your doctor, family, healthcare proxy, and friends. The Dementia Values and Priority tool is just a tool. It is not necessarily a legal document. I get this question a lot, and I actually cover Arizona as well. So we have looked at, trying to always improve end of life options. And what I have been told by our policy team is that California has a really good policy around stopping eating and drinking at the end of life. So if you're in a nursing home, what might be considered best practices, and understanding that your body, is shutting down and that you're no longer wanting food and water. However, in Arizona, it's part of our state law. They passed legislation that it's a requirement that they feed that they continue to feed you and give you fluids. So it really varies state to state. And then Compassionate Choices also has a tool to assist you and your family if you or one of your family members already has dementia. So this is called the Dementia Decoder, and it helps you prepare for a doctor's appointment by making sure that you can ask the right questions to help you get the answers you need. We also have this for cancer and then general illnesses as well. So why are you seeing the doctor? I selected, I am a caregiver, and and then you go to it will take you to this next page, and it will ask you a number of options. So what are you worried about? Understanding dementia in various stages, avoiding unnecessary tests, treatments, pain, and suffering of my loved one, ensuring that my loved one and I are informed of all treatment options, or ensuring that my loved one's treatment wishes are carried out. So my mom is a nurse, and so she has told me that she wants to avoid unnecessary tests, treatments, pain, and suffering. That is what I selected. And then once you select it, it'll take you to the next page, and it will populate a list of questions. So in this one, it populates 14 available questions, and you can go through and select which options you want. So the first question is, how would your recommendation change if I tell you that my loved one's priority is, it could be finding a cure, managing symptoms, or not receiving life-sustaining treatment, including food, hydration, just comfort care. Another question is, what is this test for, and is it necessary? What happens if it's not done? Are there other ways to get this information? Both my grandmother and father my grandmother died from Alzheimer's and my father has dementia, but for both of them, I've asked the Alzheimer's Association this, and they said it's not necessarily common, but both of them reacted this way, is every time they're transferred from their residency to the hospital, I would always get calls that they don't know where they are. I wouldn't know that my dad would fall. And the next thing I would know, I'd get a call from my dad, and he'd be like, why am I in this closet? Why am I tied up in this closet? And really, he was in a hospital room, and they had, different machines hooked up to him. But it was very disorienting. So what I've learned that was really important for him and my grandmother was that, if this test isn't going to do something beneficial that, my father would want, so if it's not going to improve his quality of life, then maybe we just skip it. And then similar with the other dementia tool, you would hit OK, and then it will create this document that you can print. And then you can also add your own questions and then go into your doctor's appointment with it and ask these questions. And then I just want to go over some additional CNC resources. So we have a card called the Finding a Partner Doctor. So this, again, encourages you to schedule a standalone appointment with your doctor and discuss end-of-life priorities. And advanced care planning consultations, again, are covered by Medicare. And then some questions on here are when making treatment recommendations, will you be honest about their impact on my quality of life? And will you honor my decision if I choose quality of life over quantity? And then the doc-to-doc line. So again, this is the free confidential resource that you can provide to your doctor. So if you're interested in having the conversation about end-of-life options with your doctor and you find out they're not familiar with the option that you're interested in, you can provide your doctor with this card or the phone number, and then they can call and speak to one of our national doctors who are experts in end-of-life care. So earlier I mentioned, they can walk you through the medical aid and dying process, but they can also walk you through voluntary stop eating and drinking, or any, even having the conversation about end of life. So as we mentioned earlier, when a doctor will talk about treatment options and how doctors say it versus how patients have it or view it, we have a really, one of our doctors is really great at having this conversation with people, if they do receive a terminal diagnosis, and helping kind of walk them through the process. And, a lot of times doctors don't realize that maybe they're not super skilled in this. She will always tell me the story about how she offered to give a training at her clinic to all the doctors around end of life. And the doctors were like, no, we know how to do that. And then all of their staff were like, no, they don't. You need to give this training. They don't know how to do it. And then we have more resources can be found on our website. I do want to go over the end of life consultation. Again, this is free. We have a translation service, so they provide the service in over 200 languages. But they can go over things like how, what are my options for end of life? How do I have a conversation with my doctor about end of life? They can go over how to interview a hospice. All hospices can be different and offer different services. So you want to make sure that you find a hospice that meets the needs that you're looking for. They can go over, how to get your advanced directives. they can go over navigating the healthcare system with you. So it's a super useful resource. They recently shared a story where a woman had been reaching out to them over the course of like 20 years. And initially it was just about conversations about, she thought maybe she had to go to assisted living. And then she ended up getting Alzheimer's. So after she got the diagnosis, she would call them. And as it progressed, she would keep calling them. And so really they can just help you kind of throughout your whole spectrum of end of life. And it's all, it's free, confidential. They don't provide any like legal services. It's just information about it. So they don't try to persuade somebody what way would be better or worse. They just provide you with the information. And then we also have a webinar series called Staying Stronger Together. So these are just different webinars that we've done across the country. So we have one that goes into more detail. They always switch. So like right now we have one on dementia that walks you more through the dementia values and priority tool. There's also some, we just had celebrated Black History Month at Compassion and Choices. So there are some webinars up there about, what are the differences between end of life care that, white people usually receive as opposed to Black and African Americans, as far as like education and information, and how we can improve that. Just a whole bunch of information. There was a really good one on there that was a whole hour long on voluntary stop eating and drinking, where 2 doctors discuss it. So that can be a great resource for you all. And then we're getting to the end here. So we do, yeah.
I was just going to say that if we have a lot of questions in the chat, so I'm wondering if you have much more to speak about, so we leave some time.
Nope. This is it, kind of. I was just going to say, if anybody wants to volunteer, we're always looking for volunteers. And then we're also just funded exclusively almost by individual donors. So if you don't want to volunteer and want to make a donation, if you support it, please do. And then the last is questions. I do want to state, I cannot answer individual questions about, like your specific diagnosis and stuff, but that would be what we would refer you to our end of life consultation, but I'm happy to answer any other questions.
Thank you so much, Angela. Wow, so much information, and I want to tell everybody, there were quite a few questions about, is there a recording? Yes, there will be a recording of this webinar, and you can actually access it on the YouTube channel of Ashby Village, and it will be available probably sometime in the next couple of days. So that's number one. Yeah, again, thank you, Angela. And also thank you to Marsha and Julie for these very touching stories about their parents. And there were quite a few comments about that. And yeah, it was very moving and inspiring too, actually. And there were also quite a few questions about what actually VICD stands for. And I just wanted, or maybe by now everybody knows, but I just want it just in case. It actually stands for Voluntary Cessation of Eating and Drinking, correct, Angela? Is that correct?
Yeah.
Yeah. Okay. And now to the questions. I mean, it's tons of questions we have here. And some of them probably have been answered by now because lots of them were actually about dementia. And so you went through this form and that was very helpful. There was one question about, do large health plans like Kaiser or Sutter have specialists who deal with advanced care planning consultations?
So do they have specialists to deal with advanced care planning?
Consultations.
I would recommend talking to your doctor, but like if you want to go through like medical aid in dying, if that's the option, some Kaiser has like a medical aid in dying clinic. So you could go talk to them specifically, the clinic, and there's like a social worker there and they'll kind of go over everything with you. I'm not sure if Sutter does, but some hospitals do. They have their own medical aid in dying coordination program where you can go talk to them specifically about that.
If you have a diagnosis like Parkinson's and can't swallow, how does the medical aid in dying medication work? Feeding tube or anal catheter don't seem like options. Is there sublingual medication? What meds are given?
Those are the two options for it, the only options for it, unfortunately.
Okay. And there was one suggestion that I actually find really good is it would be helpful to provide cards, brochures, other info about MAID to local Berkeley senior centers or to senior centers in the area in general, and add the content to their brochure rack so members and visitors could be apprised of this valuable content and what happens if the end of life prescription doesn't work. I think this is a really good suggestion to do that.
Yeah, if I could just answer that, what we do typically is a lot of our volunteers will go out and do that. So if you go to a senior center, if you're connected to it, I had my email up there. It will probably come out in the email follow-up. You can email me and I can mail you. It's all free. We send the resources. And then if you can go to the senior center and ask them to do it. California is really big. So there's only so many places I can get, which is why we count on our volunteers so much for help with that. And we do have documents, in English, Spanish, and a couple other languages as well.
Another question, if a medical doctor refuses to write in patient records their oral request for MAID, how to force or ensure that they will record it in the patient record?
How to enforce it, that they write it in there?
Oh, can they? That's the question, yeah.
I'm sorry, what was it? Can they?
Can they force that or can they ensure that it goes into the medical record?
I mean, not really because of the stay on the lawsuit right now. So we encourage you to do it. I would ask your doctor to do it. Hopefully, my hope is that your doctor would write it down, maybe just not write their objection. Just really make sure they do it. I don't think that doctors typically try to be deceptive, but we always encourage people to do it. And sometimes it's just like the doctor doesn't realize how important it is to write that first request down, because that does start it. But again, if your doctor has their own religious beliefs that they're against, that is the way the California judges now ruling it, that's their right not to put that in your medical record.
So if you have several specialists, does it matter which of these, including the primary, agrees to the medical aid in dying?
It does not. Any of them can agree to it. It's typically will be your primary because they kind of see you through the whole thing. But sometimes if you go to hospice, sometimes the hospice doctor takes over. So then the hospice doctor can then become the prescriber for it. So.
Are there any internal policies regarding home care agency caregivers being able to cooperate with this?
Yeah, so it can all be agency by agency, which is why we're trying to encourage people to list their policies on their website. So as I mentioned before, there are some that will allow staff to be present when you take the medication. Some facilities have policy that says that, staff needs to leave the room while you ingest the medication and then they can come back in. And then some won't allow it at all. So it's very tricky. It is. It's unfortunate that it's so tricky.
Somebody actually asked about you mentioned a movie that you recently watched, and what the name of that movie was, if you could say that again.
It's Last Flight Home.
Mm-hmm. Okay. So my sister now has mild cognitive impairment, so it's the third known generation to have cognitive disease. Our mother and grandmother died with advanced dementia. What are options for us if it looks like we also might develop advanced dementia?
So the options that you would have is, like I had mentioned, my coworker Her mom went through the voluntary stop eating and drinking. So it was because her grandmother had Alzheimer's and it was really bad. And so the mother decided that when she gets diagnosed, she does not want to, she was more interested in her quality of life rather than quantity of life. And so she decided to use voluntary stop eating and drinking. And my coworker has also said she feels pretty confident she's going to get the diagnosis because, you know, both her grandmother and mother have it. So when she gets the diagnosis, when she feels like, you know, it's progressing, but still when she has the full mental capacity to make healthcare decisions, she's also going to go through the voluntary stop eating and drinking process. So that's one option. And then again, you can go through the dementia tools and priority so that you are having this conversation. It's really a tool to spark the conversation with you and your family members or healthcare proxy about how you want your end of life to look if you get advanced dementia. You can, like I said, I think that you should put your own factors in, what's really important to you, and list that in there. But it's really just a tool to have the conversation and provide it documented. Another thing that we suggest is you can do a video recording of yourself, make it short and sweet, maybe 5 minutes, outlining what you want your end of life care to look like if you get a diagnosis of dementia. That way it's also easier if it's like your family's taking care of you, you know, when you have advanced dementia, for them to watch the recording and remember like, oh yes, that's right. Like mom said, like she does not want to live in a nursing home when she cannot go outside. And like understanding at that time, you know, okay, well, if she gets pneumonia, she doesn't want to be treated for that.
Somebody asked, do you recommend identifying now the second doctor who can confirm eligibility if you are not currently dealing with a terminal condition, or should we wait until the letter happens?
I think you can wait for the second. The second doctor is a lot easier because all they need to do is meet with you and determine that you have the less than 6 months with the terminal illness. It's really that first doctor that can be the challenging one to find. And a lot of times when you get a first doctor, they can help you find a second doctor. A lot of times when we do polling with doctors and do feedback with doctors, there are a lot of doctors who support medical aid in dying. A lot of them are not comfortable. They don't feel like they've received enough training on the process of medical aid in dying to be the one who's prescribing it to you, but a lot of them will be the one who does the second opinion.
How can I find a doctor in the hospice that will support VSED with comfort medications for someone who does not have a diagnosis that will result in death in 6 months?
So you can call our end of life consultation line. If you have a doctor, typically what they do, it can be very tricky we used to keep a list of all the hospices and hospitals that provide medical aid in dying. But a lot of times what happens, again, like I said, mergers will happen or different hospitals will buy them out. Or a lot of times too, just what happens is you may not realize that your doctor is he's a contracted doctor with like a Catholic hospital. So even if you're meeting him someplace else that's not a Catholic hospital, it's good to have those conversations early on so that you understand what your doctor can and cannot do for you. So I would first start by asking your own doctor. If there's a hospice near you, just call them. As I mentioned, we have volunteers who are calling hospices right now, and we're trying to keep a list, but it's just really hard to keep it updated all the time. And so if you call our end of life consultation line, if you're at the stage where you need hospice, they'll try really hard to help you find a hospice that will meet your needs. What they usually do is say like, okay, well, if you go to this hospital, you know, maybe your doctor doesn't prescribe medical aid in dying or won't go through the VSED process. But we know that this hospital has a neutral policy on it, and there's other doctors within this hospital that will provide you with this service. And so it's usually asking the social worker at the hospital or hospice. They can be, you know, the medical social workers can be a great resource for you. And sometimes what I have found in other hospitals, in particular, there's one that doesn't like to acknowledge a lot that they will provide these services. But they always call in this one doctor. And once he comes and evaluates the patient, then he'll reach out to the doctors that he knows that will take patients through this process. So yeah, it can be frustrating sometimes with the responses. We're trying to get doctors and healthcare systems and hospices to be more clear about it. But it can be very tricky. So I know it's a complicated answer, and I wish it was easier.
Yeah, it seems a lot of it is quite complicated, and with this issue, obviously. How is a patient with 6 months to live supposed to ask 2 different doctors for permission to access life-ending drugs? What if I'm bedridden, have a feeding tube, and cannot talk, drugged up on painkillers?
So that has come up in other states. So in Arizona, they recently introduced a bill with only one oral request because of that issue where it can be difficult to communicate. But unfortunately, we wish that there are ways that we could accompany things, but this is also what lawmakers are comfortable with, right? Like that we have 25 years of history showing that there hasn't been any, wrongdoing around medical aid in dying with the Oregon law. But in California specifically, when we passed the California End of Life Option Act, they had a sunset provision on it that they wanted to make. Legislators down at the state capitol were not comfortable with even the current medical aid in dying law, the way it was written without the sunset provision. They wanted to make sure that nothing bad happened, that nobody was coerced into taking medication. And then when we did SB 380, only way some lawmakers would still continue to sign on it to pass it is if we continue to keep a sunset provision on it. So now the sunset provision is 2031. So they extended it because of SB 380, but this is still not a law in California that is necessarily here forever. It does have to be revisited. So I know it can be difficult, but there's a lot of people that need to be comfortable with the laws. And our hope is too that the more states pass these laws, the more common it becomes, and then other states will also kind of work towards passing it.
That's a question, and the participant wasn't quite sure if you can answer it, but can a patient who is receiving chemo be in hospice, or does hospice require termination of all treatment?
So as long as you have a terminal illness of 6 months or less, you can still be in hospice. But if you don't have the terminal illness and you're getting chemo for cancer, you would be in palliative care. But yes, you can, if you want to keep using chemo and get hospice care, you could do that.
And there was a question about the form, the yellow form. What is the yellow form called, and where can I get one? That was from the beginning of your talk, I think. That yellow form. It
is a do not resuscitate form.
Okay.
So you can usually find them online at I usually just Google California do not resuscitate. And I do want to state, sorry about that, I was mixing that up. You cannot receive chemo and go on hospice. I was thinking of palliative care. So
okay.
I just talked for a long time, so I'm sorry, but just to clarify.
Yeah, as I said, lots of questions about dementia. Do you think it's necessary to have an additional advanced care directive related specifically to the dementia? I mean, you kind of answer that. I mean, with the form that you showed. And can one delegate in an AHD? I think it's probably at ACD, the Advanced Care Directive, person to choose and implement MAID?
No. So in order to get medical aid in dying, you have to be mentally competent in making your own healthcare decisions, and you have to make the oral request and everything. So the Advanced Care Directive would mean that you're no longer able to voice that or make those requests, which is why you can't put that in your Advanced Care Directives.
Okay.
It's a lot to make sure that people are not being all of these are safeguards that were in place to make sure that people are not being taken advantage of or being coerced or forced to take this medication.
So here is one question. What are the suggestions for people who live alone, whose families are in other states and themselves older and infirm, and the patient wants to die at home?
It can be tricky. Again, I would, reach out to different hospices. There are death doulas available. But I would first start with contacting the hospices and seeing, what options they have for suggestions. The problem with hospice a lot of times is they don't provide 24-hour care. But I would check with them first and see what the options are for you. If you have neighbors that might be willing to come in and help, it is tricky. Our system in America is not really set up to make us have the best end of life that we all want, but we're working on trying to change it. So
there's actually one comment, and it might be a good question or good comment to actually finish this. It's SB 380 seems to protect doctors or facilities, barely does anything for the patient! Exclamation point. So your comment to that?
SB 380 was set to help the patients. So it was to be more transparent about whether or not they provided medical aid in dying. It changed the waiting period from 15 days to 48 hours. It got rid of this other thing that I didn't mention, but it was like a fourth paper that you had to fill out saying that you wanted it. So we just did away with that. I think what protects the doctors more, the original California End of Life Option Act and all medical aid in dying legislation across the country always gives doctors the option to opt out. So what SB 380, what maybe seems like it's protecting doctors more, is the fact that there's a lawsuit where the Christian Medical and Dental Association sued the state over SB 380. And now that piece is on hold where the doctor can opt out even more. Does that clarify it?
I guess so. Yeah. Somebody said I missed the part about how one can get morphine with VSED.
So just through your doctor, asking your doctor if you're in hospice care, asking them for comfort care. That's why we recommend that once the VSED process starts, that you receive 24-hour care and supervision by a doctor. In previous decades, I think people would do it without that. So sometimes we were recently talking about it, like if you knew somebody that did it, back in the 70s, their experience might be very different than what you would have today because it is more widely known, and they will provide comfort care most often. So.
And lastly, besides a lot of thank yous, there is a question about the volunteer positions that you mentioned. What type of volunteer positions are available?
So our volunteers will help us, again, it could be dropping off pamphlets at your local, community center, at the library, at the senior center. We have other volunteers that will do like book clubs around. Our founder, Barbara Coombs, she wrote a book called Finish Strong. So they'll order this book and it will walk them through all the chapters about end of life. And then we have like questions to help with the book club. Some of our volunteers will offer to host a film screening. So they'll, host a film screening in their home, invite some of their friends over, and then we can help lead the discussion afterwards around the film. Our volunteers also are calling hospices and hospitals and trying to get the policies on the website. They give presentations in the community. If you're a retired doctor or nurse or social worker or healthcare provider, we can train you to give presentations to other social workers and doctors. We do peer-to-peer training, so you can go into hospices and train them on medical aid in dying. Or a lot of hospices, sometimes they want to offer more services to the family members. So we'll do trainings with them. Somebody could have done this training today if they wanted to. They just go out and do presentations. We work with people to try to find out what they're comfortable in and what their skill set is. So.
Okay, great. So we come to the end of our Q&A here, and somebody asked about the forms and brochures that you mentioned, and I'm sure in the email that will go out to everybody who participated today, that will all be mentioned there. And now I give it to Roberta.
Okay. Hi, guys. Give me a minute here. Thanks, Angela. This was an incredibly wonderful and informative presentation. And I want to thank Marcia and Julie, who shared their deeply personal stories about their family experiences with their loved ones as well. And Jessica, our coordinator of volunteers, for making sure all our technology and Zoom addresses were working properly. Thanks so much. And to Sigrid Duisberg, our events coordinator, an enormous thank you. I don't know quite how she does it, but she's a whiz at organizing the questions in our chat, no matter how numerous, so that they come out in the right order and with appropriate priority. Thanks, Sigrid. Also, I want you to know this recording, the recording of this program will be available on your YouTube channel at Ashby Village within 48 hours. And a link will be sent by email to you at that time. Also, feel free to let your friends know about the recording in case they missed today's presentation. Our programs are free to attend, and if you'd like to donate to Ashby Village, the link is in the chat and will also be in the follow-up email. Thank you again, everyone, for joining us today, and have a great rest of your day.